Hello. Today we are covering the behavioral objectives for week 6. Let's begin. Cognitive impairment, by definition, it has 3 components: subaverage intelligence, an IQ of 75 to 70 or below, deficits in adaptive functioning in 2 or more in the following areas: communication, self-care, home living, social skills, leisure, health and safety, self-direction, functional academics, community use, and work. The onset is before 18 years of age. Early signs of cognitive impairment: there is no response to contact, voice, or movement, irritability, poor or slow feeding, poor eye contact during feeding, diminished spontaneous activity. Causes: chromosomal abnormalities like Down syndrome, which is trisomy 21, Fragile X, infections or intoxications, rubella, syphilis, chronic lead ingestion, fetal alcohol syndrome, trauma, inadequate nutrition, and metabolic disorders like PKU or phenylketonuria. This must be assessed when the child is 24 hours old at least, and most accurately assessed after drinking formula or breast milk due to the protein. Hypothyroidism is also a problem, childhood meningitis, hypoxia, and others. Diagnosis: history and physical, chromosome analysis, blood chemistries, lead levels, a Denver Developmental Screening Test 2, developmental intelligence and adaptive functioning tests, ages and stages developmental screening, a complete neurological test, Stanford-Binet IQ test. Early screening is important in high-risk individuals. Classifications of cognitive impairment by level. So we're looking at the IQ. Mild is an IQ of 50 to 55 to approximately 70 to 75. 85% of people with cognitive impairment fall in this category. Preschool, birth to 5 years of age. And yes, I realize that birth to 5 years of age doesn't typically encompass all of preschool, but you're going to notice for the cognitive impairment, the ages are a little bit different than what we would normally see. And so this is an exception to the rule. So maturation and development. It's often not noticed as an impairment by the casual observer, but they are slower to walk, feed themselves, and talk than most children. They follow the same sequence in development as normal children. They're just a little bit slower. School age 6 to 21 years. Training and education. They can acquire practical skills and useful reading and arithmetic from a 3rd to 6th grade level with special education. They can be guided towards social conformity and meet the age of a mental age of 8 to 12 years. An adult, 21 and over, social and vocational adequacy. So here they can usually achieve social and vocational skills adequate to maintain self-care. They may need occasional guidance and support when under unusual social or economic stress. They can typically adjust to marriage, but not child rearing. Moderate, which is 35 to 40 to 50 to 55 IQ. About 10% of people with cognitive impairment are at the moderate level. Preschool, maturation and development. Here they have noticeable delays in motor development, especially in speech. They respond to training in various self-help activities. School age, they can learn simple communication, elementary health and safety habits, simple manual skills. They do not progress in functional reading or arithmetic, and they achieve a mental age of 3 to 7 years. Adults, they can perform simple tasks under sheltered conditions, participate in simple recreation. They can travel alone in familiar places, and usually they are incapable of self-maintenance. You wouldn't want to leave a 3 to 7-year-old alone. Severe, 20 to 25 to 35 to 40 is the IQ level. Here, preschool, marked delays in motor development, little or no communication skills. They may respond to training in elementary self-care, like feeding themselves. School age, they usually walk unless they do have a specific disability that prevents them from doing so. They have some understanding of speech and some responses. They can profit from systematic habit training, and they typically achieve a mental age of a toddler. They can conform to daily routines and repetitive activities. They do need continuous direction and supervision in a protective environment. Profound, this is below 20 to 25. Here in preschool, they have growth delays, minimal capacity for functioning in sensory motor areas, and they need total self-care. They can't do anything for themselves. School age, they have obvious delays in all areas of development. They do show basic emotional responses. They may respond to skillful training and use of their legs, hands, and jaws. They need close supervision. And this person achieves a mental age of a young infant. They may walk, but they do need complete custodial care. They may have primitive speech, and they do benefit, like everybody, from regular physical activity. There is no cure. We do want to avoid preventable causes like fetal alcohol syndrome, lead poisoning, trauma, etc. Nursing, we want to educate using effective teaching strategies, promote optimal development, safe environment, promote self-care skills, and have a plan for the future. You want to give parents information for resources and rights regarding education of their child. Under the Public Law 101-476, the Individuals with Disabilities Education Act of 1990, basically it states that states are required to provide educational opportunities for all children with disabilities from birth to 21 years of age. Home care alternatives. Some parents may choose to give their children up for adoption after diagnosis. Foster care, group homes, semi-independent living, and other institutions are also available. If the person lives with their family, day programs, special vocational education, and respite care services, often through the regional centers, are available. Down syndrome, the most common chromosome abnormality of a generalized syndrome. About 95% of the cases are due to extra chromosome 21, group G. Again, this is called trisomy 21. Women who are 35 years of age, this can occur in 1 out of every 350 live births. Women 40 years of age, it's 1 in 100. So obviously it increases as the woman gets older. The thing to remember is that 80% of Down syndrome are in women under the age of 35. Paternal age is also a factor, especially in men 55 years and older. So there is a table in your textbook that has all of these signs and symptoms. I'm not going to read every single one, so please make sure you do so. Head, here we're going to see separated sagittal sutures. Eyes, excuse me, eyes, they have the oblique palpebral fissure, which is the upward and outward slant. The nose, they have a small depressed nasal bridge. The ears, they have short, small penis. The mouth is a high arched, narrow palate. Teeth, they can have a delayed eruption. The chest has a shortened rib cage. Neck, the skin is excess and lax. Abdomen, protruding and has lax muscles and is flabby. They can also have an umbilical hernia. Genitalia, a small penis and cryptorchidism. Therefore, we need to assess for did the testes descend. Hands, they can have broad, short, stubby fingers and a transverse palmar crease. Feet, they have a wide space between the big and second toe, and they also have a plantar crease between the big and second toes. Musculoskeletal, hyperflexibility, muscle weakness, and atlantoaxial instability. The skin can be dry and cracked. They often have a reduced birth weight. Diagnosis. Here it's chromosome analysis, low intelligence, obviously cognitive impairment. We want to assess for heart defects because it's not uncommon for them to have a septal defect. So we need to do ECG or a 3D echo. They also have an increase in hearing and eye problems, so we want to assess for that. They have an increase in respiratory tract infections, hypothyroidism, delayed growth and sexual development, and an increased incidence of leukemia. So we really do have to assess for all of these things and continue to monitor for them. If the child is involved in sports that may stress the head and neck, an X-ray for atlantoaxial instability should be done. Signs and symptoms, neck pain, weakness, or torticollis would indicate problems. They can also be at high risk for spinal cord compression if they have this issue. And signs and symptoms here would indicate persistent neck pain, changes in sensation, loss of established motor skills, and bowel or bladder control. So if they had bowel and bladder control and they lost it, that would be a concern. Treatment, there is no cure. You want to correct correctable anomalies, do your routine histories and physicals, immunizations, sight and hearing testing, and promote optimal health and development. Autism spectrum disorders. Autism spectrum disorders, or ASD, are complex neurodevelopmental disorders of brain function accompanied by intellectual and social behavioral deficits. So the pathophysiology. ASD is now recognized as a genetic disorder of prenatal and postnatal brain development. Immune and environmental factors like viral infections may interact with the genetic susceptibility to increase the development of ASD. They may have difficulties in social communication and social interaction. In general, children with ASD demonstrate several peculiar and often seemingly bizarre characteristics, primarily in social interactions, communication, and behavior. They may have an inability to maintain eye contact with another person, avoidance of body contact, and language delay at a very early age. Limited functional play. They may interact with toys in an unusual or odd manner. Children with ASD may have significant gastrointestinal symptoms. Constipation is a common symptom and can be associated with acquired megarectum in children with ASD. Diagnostic evaluation. Early recognition of behaviors associated with ASD is critical to implement appropriate interventions and family involvement. Developmental history is essential. Physical examination for genetic syndromes or neurological findings are also very important. Often young children present with behavioral difficulties. Treatment. The most promising results have been through highly structured and intensive behavior modification programs. In general, the objective in treatment is to promote positive reinforcement, increase social awareness of others, teach verbal communication skills, and decrease unacceptable behavior. Providing a structured routine for the child to follow is key in the management of ASD. Nursing care management. So some nursing diagnoses include impaired social interaction, impaired verbal communication, issues with growth and development, ineffective family coping, risk for injury, caregiver role strain. Planning and implementation, we want highly structured and intensive behavior modification programs. These help reinforce positive behaviors and decrease negative or inappropriate behaviors. Decreasing environmental stimuli, lots of sounds and lights can be bothersome. Maintain a safe environment, provide close supervision. Self-abusive children need protective mechanisms in the least restrictive manner as possible. Promote parental coping. Maintain the hospitalized child's daily routine as much as possible to minimize stress. Encourage activities and specialized educational programs to the child's ability to promote optimal growth and development. Because physical contact often upsets these children, minimum holding and eye contact may be necessary to avoid behavioral outbursts. Care must be taken when performing procedures on these children or administering medication to them or feeding them. Children with ASD need to be introduced slowly to new situations. Communication should be at the child's developmental level, brief and concrete. Patient and family teaching. Parents need expert counseling early in the course of the disorder. We want to teach the family proactive care that reduces a child's risk for injury. We want to educate the parents about behavior modification methods, as well as support groups, and experts in ASD provide needed education and support for parents. You can even refer the parents to the Autism Society of America. Warning signs for autism include no babbling by 12 months, no pointing or using gestures by 12 months, no single words by 16 months, no two-word utterances by 24 months, and a loss of language or social skills at any age. Next is attention deficit hyperactivity disorder. This is a developmental disorder involving inattention and or hyperactivity. more common in boys than in girls. Diagnostic criteria for attention deficit hyperactivity disorder are, it's broken down into two categories. So the first part is A, and here they have 6 or more of the following signs and symptoms for children up to age 16. And then if they're 17 or older, they only need to have 5 of the following signs and symptoms. And then they need to have these symptoms of inattention persist for at least 6 months to a degree that is maladaptive and inconsistent with developmental level. So what are the signs and symptoms? Inattention. So here we often will see that they are failing to give close attention to details, or they make careless mistakes in schoolwork, work, or other activities. They often have difficulty sustaining attention in tasks or play activities. They often don't seem to listen when spoken to directly. They often don't follow through on instructions and fail to finish schoolwork, chores, or duties in the workplace. And this is not due to oppositional behavior or failure to understand the instructions. They often have difficulty organizing tasks and activities. They often avoid or dislike or are reluctant to engage in tasks that require sustained mental effort, like schoolwork or homework. They often lose things necessary for tasks or activities, like toys, school assignments, pencils, books, or tools. They're often easily distracted by extraneous stimuli, and they are often forgetful in daily activities. The next component, if it's present, includes, again, 6 or more signs and symptoms for children up to age 16, and then 5 signs and symptoms for 17 and older of hyperactivity and impulsivity, and these need to again persist for at least 6 months to a degree that is maladaptive and inconsistent with the developmental level. So hyperactivity, here they fidget with their hands or feet or squirm in their seat. They often leave their seat in the classroom or in other situations in which remaining seated is expected. They often run about or climb excessively in situations in which it is inappropriate. Adolescents and adults may actually feel these subjective feelings of restlessness. They often have difficulty playing or engaging in leisure activities quietly. They're often on the go, almost as if they are driven by a motor, and they also talk excessively. The signs of impulsivity would include blurting out answers before a question has been completed, difficulty waiting their own turn, or interrupting or intruding on others, butting into conversations or games. Extra things we want to take a look at is that some of these hyperactive, impulsive, or inattentive symptoms that caused impairment were present before the age of 12. It occurs in 2 or more settings, so it's not just at home. It's usually at home and at school, or also at work. So it's seen in at least 2 settings. There must be clear evidence of clinically significant impairment in social, academic, or occupational functioning. And these symptoms don't occur exclusively during a pervasive developmental disorders, schizophrenia, or other psychotic conditions. Treatment. We want to focus on family education, counseling, proper classroom placement, environmental manipulation, behavioral therapy, and medication. Medication. The most common medications are psychostimulants like methylphenidate, also called Ritalin, that's the trade name. What this does is it enhances dopamine and norepinephrine levels, which inhibits impulsiveness and hyperactivity. What this does is this helps to improve attention and task performance. We want them to take it in the morning at 12 noon. That way it's working while they're at school. Side effects include anorexia, so we can give it with meals, sleeplessness, so you want to give it early, headache, weight loss, abdominal pain, increased crying, irritability, cardiovascular stimulation. We want them to avoid caffeine because this can actually decrease the medication's effectiveness. Parent information. You want to minimize outside distractions if the child needs to sleep or concentrate. There must be consistency at home and at school. Children with ADHD need an orderly, predictable, and consistent classroom environment with clear and consistent rules. Homework and classroom assignments may need to be reduced, and more time may need to be allotted for tests to allow the child to complete the task. Verbal instructions should be accompanied by visual references, such as written instructions on the blackboard or their whiteboard. Schedules may need to be arranged so that academic subjects that are taught in the morning when the child is experiencing the effects of the morning dose of medication. Regular and frequent breaks inactivity are helpful because sitting in one place for an extended time may be difficult. It may be helpful to list all activities a child needs to complete before school, during school, and after school. We want to give them positive reinforcement for meeting these goals. Unfortunately, yes, they do need appropriate discipline for infractions like timeouts, removal of privileges, and an increase in chores. This needs to be done immediately for behavior modification. We want to promote self-esteem by pointing out the child's positive behavior. Anytime the child's doing something that you want them to do, give them lots and lots of praise. Parents need emotional support also. They may need parenting classes because they have a very active and hard to handle child. Strabismus. This can be called squint or malalignment of eyes. It can be estropia, which is the inward deviation of the eye, or extropia, the outward deviation of the eye. Pathophysiology. This may result from muscle imbalance or paralysis, poor vision, or congenital defects. Because visual accesses are not parallel, the brain receives two images and amblyopia can result. Clinical manifestations. So they may be squinting their eyelids together or frowning. They may have difficulty in focusing from one distance to another, inaccurate judgment in picking up objects, inability to see print or moving objects clearly, closing one eye to see, tilting the head to one side to see. And if this is combined with refractive errors, you may see any of the above manifestations as well as refractive error signs and symptoms like diplopia, photophobia, dizziness, and headaches. The treatment really depends on the cause of the strabismus. It may involve occlusion therapy, which is patching the stronger eye. That way the weaker eye does get stronger, or surgery to increase visual stimulation to the weaker eye. Early diagnosis is essential to prevent vision loss. Bullying. This is a recurring activity that intends to cause harm, distress, or control towards another person. It most often occurs in school hallways or on the playground where supervision is minimal, but peers are present to witness the attack. Sadly, cyberbullying involves an electronic medium to harm or bother an individual and can even be more harmful than traditional bullying because the attack can instantly reach a much larger audience while actually even allowing the bully to remain anonymous. Children who are targeted for bullying often have internalizing characteristics such as withdrawal, anxiety, depression, low self-esteem, and reduced assertiveness that may make them an easy target for bullying. Bullies are generally defiant towards adults, manipulative, and likely to break school rules. They have aggressive attitudes, a positive view of violence, a lack of empathy, and may experience or witness violence or abuse at home. Boys who bully tend to use physical force, referred to as direct bullying, but girls usually use bullying methods such as exclusion, gossip, or rumors, and this is referred to as indirect bullying. The long-term consequences of bullying are significant. Future problems of bullies include a higher risk for conduct problems, hyperactivity, school dropout, unemployment, and participation in criminal behavior. Chronic bullies seem to continue their behaviors into adulthood, negatively influencing their ability to develop and maintain relationships. Victims of bullying are at increased risk for low self-esteem, anxiety, depression, feelings of insecurity, loneliness, poor academic performance, and psychosomatic complaints such as feeling tense, tired, or dizzy. School personnel play an important role in implementing anti-bullying interventions in schools. However, research has also recognized that involving the whole family in anti-bullying programs greatly increases success. Enuresis. This is a urinary incontinence in a child who should be potty trained. Primary is a child who was never potty trained. Intermittent is they've had occasional dryness. Secondary is bedwetting in a child who was trained for 6 to 12 months. This is associated with stress, infection, and sleep disorders. Nocturnal bedwetting usually stops by 6 to 8 years of age. To diagnose enuresis, the child must be over 5 years of age and wet the bed at least 2 times a week for 3 months. Remember, The bladder volume of a child is their age plus 2, and it's that many ounces. So what that means is if a child is 3 years of age, well, 3 plus 2 is 5, so their bladder will hold 5 ounces. Assessment questions. Are there any new or chronic stresses in the child's life? Does a child void often or have urgency? Is their child frequently thirsty? Do they have diabetes? Does the child have burning when urination? Has a child had a urinary tract infection in the past? Treatment. So first and foremost, of course, we're going to try fluid restriction. Often we'll give maybe the first 40% of the fluid earlier in the day, and then the second 40% of their fluid in the middle of the day. And then we don't want to give them too much later on in the afternoon to evening. Depending on the child's age, definitely you want to think about restricting their fluids before they go to bed. Bladder exercises can also be very beneficial. Here, the child's going to drink a large amount of fluid, and then they're going to hold their urine as long as they can, and then they're going to practice voiding and stopping midstream. So they will void and then stop, and then void and stop. These exercises should continue for at least 6 months. Time voiding, this is where the child with diurnal enuresis is instructed to void every 2 hours and to use a double voiding pattern. This helps to train the bladder to completely empty and avoid overdistension. Enuresis alarms. This is a detector strip that's attached to the child's underwear. The alarm sounds a buzzer that alerts the child when the wetting occurs, so then the child can wake up and finish going to the restroom. Here you want to allow the child to use the alarm on a doll first, and that way they can get comfortable and used to the system. Reward system. We really want to set realistic goals for the child and reinforce dry days or nights with stars and stickers. Sometimes patients can also be given medications. TCAs like imipramine, antidiuretics, antispasmodics, really depending on the problem would determine the medication they give. Desmopressin, this can be given an hour before bedtime, is prescribed for special situations in cases of nocturnal enuresis. Oxybutynin for diurnal enuresis to relieve urgency, spasms, and frequency from bladder irritability. And then topiramate, imipramine, is given 1 hour before bedtime, and this may be used to inhibit urination. Dietary changes are avoiding fruit and fruit drinks, carbonated and caffeinated drinks, and citrus fruits after 4 p.m. Treatment typically occurs over a 6 to 8 week period, and then they gradually will taper off the medications over a 4-week period. For nurses, please be aware that treatment varies with the cause. You want to provide emotional support to the child and the parents. Don't embarrass or punish the child. Don't refer to enuresis as an accident. Accidents can be prevented. Have the child assist in changing the sheets. Encopresis. This is a repeated voluntary or involuntary fecal incontinence. Predisposing factors are inconsistent training and stress. Primary, they were never potty trained by 4 years of age. Secondary, they were continent, but now they are not. And the problem is either voluntary or involuntary holding the BM, causing constipation, resulting in the lower bowel dilation and incompetent inner sphincter. Loose stool then can leak around the hard feces. The child may not be able to feel the need to defecate, or it may be very painful. Often incontinence will occur after they have a bath. Some causes would include environmental changes like having a new sibling, moving to a new house, changing schools, or having even a new or unfamiliar toilet. Other causes can include abnormalities in the digestive tract and medical problems. Psychogenic encopresis, this is soiling caused by emotional problems, and this can be related to issues with the parental relationship. Management, physical assessment, rectal examination, abdominal x-rays, dietary modifications. You want to eliminate milk and dairy products, increase high fiber foods, increase fluids, stool softeners, having a toilet ritual. This will help to establish normal defecation patterns. If they have a fecal impaction, as long as they are not having issues with dysphagia or vomiting because we don't want them to aspirate mineral oil, they can have mineral oil. They can also use osmotic laxatives like lactulose, Miralax, and magnesium hydroxide. So for nursing, we want to educate on normal defecation, toilet training, treatments, and medication, encouraging the child to sit on the toilet for 10 to 15 minutes after meals for intervals of 10 to 15 minutes. Providing a quiet activity, making sure that the toilet is comfortable and non-threatening. Placing a footstool before their feet actually will help to relax the abdomen and make them more comfortable. There is something called a squatty potty that you can put around the toilet, the bottom of it, and you can have the child put their feet on top of it. Positive reinforcements like stickers and praising the child and just really letting them know how proud you are that they are being able to be continent. Definitely, please make sure we are giving them plenty of fluids and maintaining the dietary modifications of using a high fiber diet. Again, we may be using lubricant suppositories, mineral oil laxatives, timed toileting, behavioral therapy, psychotherapy may also be needed. Reassure the child and the parents that they can have normal functioning. We're going to change the topic a little bit. Now we're going to talk about neurological conditions. The first one we're going to talk about is meningitis. This is an inflammation of the meninges. The three main types are bacterial, viral or aseptic, and tuberculosis. Strep pneumonia, the most common cause of meningitis in kids 3 to 11 years of age. It's 3 months to 11 years of age. The Hib and S pneumonia vaccine has dramatically decreased the number of cases of meningitis. Pathophysiology, basically the bacteria will spread to the central nervous system. Inflammation, exudate, white blood cells accumulate and can cause varying degrees of tissue damage. The brain becomes hyperemic and edematous, and then the entire surface of the brain is covered with a layer of purulent exudate. As the infection extends to the ventricles, thick pus, fibrin, or adhesions may occlude the narrow passages, obstructing the flow of the cerebral spinal fluid. Prevent with vaccines like the Hib and the pneumococcal starting at 2 months of age, and then using the meningococcal saccharide for kids between 11 and 12 years of age, and then a booster at 16 years of age. If you have a college student who has never had a meningococcal vaccine, especially if they're going to be living in dorms, it's very critical that they get the meningococcal vaccine when they start college. Signs and symptoms. Children and adolescents, usually they're going to have an abrupt onset of their signs and symptoms, fever, chills, headache, vomiting, alterations in sensorium, seizures which can often be the initial sign, irritability, agitation. They may develop photophobia, delirium, hallucinations, aggressive behavior, drowsiness, stupor, and coma. Nuchal rigidity may progress to opisthotonus. Opisthotonus is when the head is tilted backwards and then their back arches backwards. So they're like in a bow shape. A positive Kernig sign is when they are supine and the leg is bent at a 90 degree, and then when you straighten it, they will complain of pain. Brudzinski's sign is when you bend the head forward and the chin is going towards the chest, and the leg automatically will flex forward towards the body. They can have hyperactive but variable reflex responses. Signs and symptoms peculiar to the individual organism would include petechial or purpuric rashes from meningococcal infection, especially when it's associated with a shock-like state. Joint involvement can be meningococcal as well as Haemophilus influenza infection, and then chronically draining ears could also be a pneumococcal meningitis. Infants and young children. The classic picture above is rarely seen in children between 3 months and 2 years of age. Usually here you're going to see fever, poor feeding, vomiting, marked irritability, frequent seizures, often accompanied by a high-pitched cry, bulging fontanelles, nuchal rigidity may or may not be present. Brudzinski's and Kernig signs are not helpful in diagnosis. It's really difficult to elicit this and evaluate it in this age group. Rocking or cuddling irritates the infants. So this is just an alert because this is really in a medical emergency. If a petechial rash or purpuric rash is present, this is very emergent because it can be that the patient has meningococcemia, which has a 90% mortality rate. Diagnosis: CBC, a metabolic panel, blood cultures, sometimes nasal and throat cultures. Lumbar puncture is the definitive diagnosis. So here, when they're doing the lumbar puncture, they're going to collect cerebrospinal fluid and they're going to evaluate it. And what we expect to see with bacterial meningitis is an elevated white blood cell count, elevated protein, elevated pressure, a decrease in the glucose, and a positive culture. The color is turbid or a little cloudy. Treatment: large doses of IV antibiotics like ampicillin, cefotaxime, ceftriaxone if they're over 6, also penicillin G. And they'll be taking this until the CSF has a negative culture and normal glucose. There are quite a few complications with bacterial meningitis, such as ADHD, deafness, blindness, cognitive impairment, cerebral palsy, muscle weakness, seizures, septic arthritis, septicemia, subdural effusions, syndrome of inappropriate antidiuretic hormone, DIC, and hydrocephalus. Nursing: this patient needs to be in droplet isolation during diagnosis and at least 24 hours after starting antibiotic therapy. Please refer to the hospital-specific policies. Maintain a dark, quiet room due to light and noise sensitivity. Assess vital signs, neurological status, INO, IV fluids, seizures, if they are having seizures, and even if they're not, you may want to maintain seizure precautions just for safety. Monitoring for signs and symptoms of increased intracranial pressure in your infants and very young children, measuring head circumference. Tylenol for temperature, headache, and pain. If they're not vomiting, high protein and a high calorie diet with small frequent meals may be appropriate. Remember, they can be very nauseous. If they are in a position of aposthotness, you do want to place them on their side. If they have a decreased level of consciousness, keep them NPO. In general, we will discharge them once they've completed antibiotics, and we want to be able to identify any complications and treat them early, so they do need to have follow-up. Viral meningitis. This is most often caused by an enterovirus. Signs and symptoms here include headache, fever, malaise, then in a couple of days, signs of meningeal irritation, abdominal pain, nausea, vomiting, and a maculopapular rash. These signs and symptoms typically subside in 3 to 10 days. The child has no complications. Here, the diagnosis is actually the same. They'll do all the same diagnostic tests that they did for bacterial meningitis. The thing is that the cerebral spinal fluid looks different. Here, it may have slightly elevated WBCs, a normal glucose, a negative culture. Protein may be normal or slightly elevated, and the color is clear or maybe just very slightly cloudy. The treatment is the same as bacterial meningitis, though, until it is confirmed that it is viral. Then we just treat them symptomatically. Next, we're going to talk about seizure disorders. Here, seizure disorders are electrical discharges that disturb brain function, causing changes in the level of consciousness, involuntary muscle movements, altered behavior, and sensory signs and symptoms. Epilepsy is 2 or more unprovoked seizures more than 24 hours apart, and they can be caused by many, many problems. So pre-seizure, they may have an aura, a visual or other, some kind of warning where they feel like, oh my God, I know I'm going to have a seizure. It could be a smell, a sensation in their stomach. And typically we see these auras with people that have complex partial seizures. Ictal, this is the time during the seizure. And remember, we do want to time our seizures as soon as they start, look at the clock. Post-ictal is the time after the seizure. 2 major categories of seizures. You have partial or focal seizures, and there are 3 types here. And then we have generalized seizures, and there are quite a few types there. We're going to talk about each of them. So partial seizures. The first one is simple partial seizures with motor signs. This is characterized by localized motor symptoms, somatosensory, psychic, autonomic symptoms, combination of these abnormal discharges, and they tend to remain unilateral, meaning that they occur on one side of the body. Signs and symptoms would be aversive seizure, which is the most common motor seizure in children. The eye or eyes and head turn away from the site of the focus. There is an awareness of the movement or a loss of consciousness. They can have a Rolandic or Sylvan seizure, and this is a tonic-clonic movements involving the face, salivation, arrested speech, most common during sleep. A Jacksonian march, which is rare in children, this is where you'll see an orderly sequential progression of clonic movements beginning at a foot, hand, or face and moving or marching to adjacent body parts. Next, you'll have simple partial seizures with sensory signs. These are characterized by various sensations including numbness, tingling, prickling, paresthesia, or pain originating in one area, the face or the extremities, and spreading to other parts of the body. Visual sensations or formed images, motor phenomena such as posturing or hypertonia tend to be more uncommon. This is uncommon actually under the age of 8. The motor phenomena such as posturing or hypertonia are things you will see or could see. But the partial seizures with sensory signs are uncommon under 8 years of age. Complex partial seizures, these are also called psychomotor seizures. These are observed more often in children from 3 years through adolescence. They are characterized by a period of altered behavior, amnesia for the event, so they don't remember, an inability to respond to environment, impaired consciousness during the event, drowsiness or sleep usually follows the seizure. Confusion and amnesia may be prolonged. Complex sensory phenomena, which is just a fancy way of saying an aura, they may have those. And basically, like I said before, they can have a strange feeling in the pit of their stomach that goes to their throat, or they may have an unpleasant odor or taste or auditory or visual hallucinations. They just have like a sense that something's not right, something's going to happen. They may have strong feelings of fear or anxiety, a distorted sense of time and self. Small children may emit a cry and attempt to run for help. Patterns of motor behavior. Here you can see stereotypic, similar with each subsequent seizure. They may suddenly cease activity, appear dazed, stare into space, become confused and apathetic, and become limp or stiff, or display some form of posturing. They may be confused. They may perform purposeless, complicated activities in a repetitive manner, such as walking or running, kicking and laughing, or speaking incoherently. This is most often followed by post-ictal confusion or sleep. They may be oropharyngeal activities such as lip smacking, chewing, drooling, swallowing, and nausea or abdominal pain, followed by stiffness, a fall, and post-ictal sleep. Rarely manifest as rage or temper tantrums. Aggressive acts are very uncommon during this kind of seizure. Next, we're going to talk about the generalized seizures. These are tonic-clonic, and this is the most common and most dramatic of all seizure manifestations. This one in the past was referred to as a grand mal seizure. So if you hear that term, this is the one that they're talking about. This one usually occurs without warning. The tonic phase lasts approximately 10 to 20 seconds. Signs and symptoms: the eyes roll upward. There's an immediate loss of consciousness if they are standing. They will fall to the floor or ground. They stiffen in a generalized symmetric tonic contraction of the entire body's musculature. The arms are usually flexed, legs, head, and neck extended. They may utter a peculiar piercing cry. They may be apneic and may become cyanotic. They can also have an increase in salivation and loss of a swallowing reflex. Then next comes the clonic phase. This lasts about 30 seconds, but can vary from only a few seconds to a half hour or longer. Signs and symptoms: this is violent jerking without movements violent jerking movements as the trunk and extremities undergo rhythmic contractions and relaxation. They may foam at the mouth, they may be incontinent of urine and feces, and as the event ends, the movements become less intense, and then they slowly start to stop. Status epilepticus, this is a series of seizures at intervals that are too brief to allow the child to regain consciousness between the time one event ends and the next one begins, and lasts longer than 30 minutes. This requires emergency intervention, usually IV lorazepam. This can lead to exhaustion, respiratory failure, and death. It has been suggested that the term impending status epilepticus be used for a continuous or series of seizures lasting between 5 minutes and 30 minutes. We're going to talk about this one a lot more thoroughly in a little bit. The post-ictal stage, here they appear relaxed. They may remain semi-conscious and difficult to arouse. They may awaken in a few minutes. They may remain confused for several hours and have poor coordination. They may have difficulty with fine motor movements. They may have visual and speech difficulties. They may vomit or complain of a severe headache. When they're left alone, they will sleep for many hours. And then once they awake, they'll be fully conscious. And often after that, they feel very tired and they may complain of sore muscles and a headache, and they don't typically, they don't remember the event. Absence seizures or petit mal seizures, that's also an old term for this. So if you hear someone say a petit mal seizure, they're referring to absence seizures. The onset usually between 4 and 12 years of age, more common in girls than in boys, usually stop at puberty. There's a brief loss of consciousness, minimal or no alteration in muscle tone. They may go unrecognized because there's little change in the child's behavior. They do have an abrupt onset. They can develop suddenly 20 or more attacks daily. And often what happens is they are mistaken for inattentiveness or daydreaming. Events can precipitate absent seizures are things like hyperventilation, hypoglycemia, stress, like emotional or physiologic, fatigue, or sleeplessness. Signs and symptoms. Here you would see brief loss of consciousness. It can appear without warning or aura. It usually lasts about 5 to 10 seconds. There's a slight loss of muscle tone. If the child is holding something, it might cause them to drop it. They're able to maintain their postural control. They seldom fall. Minor movements such as lip smacking, twitching of the eyelids or face, or slight hand movements not accompanied by incontinence, amnesia for episode, they may need to reorient to themselves to the previous activity. Atonic and akinetic seizures. Here, these are characterized by an onset usually between 2 and 5 years of age, sudden momentary loss of muscle tone and postural control. These can also be referred to as drop attacks. Events recur frequently during the day, particularly in the morning hours and shortly after awakening. Here are the signs and symptoms. There is just a loss of tone that causes the child to fall to the floor violently. They're unable to break their fall by putting their hand out. Here they can actually incur serious injuries to the face, head, or shoulders. Note that the loss of consciousness is typically only momentary. Myoclonic seizures. Here, this is a variety of seizure episodes. They may be isolated as benign essential myoclonus, may occur in association with other seizure forms. Here they're characterized by sudden brief contractures of the muscle or muscle groups. They occur singly or repetitively. There is no post-ictal state. They may or may not be symmetric, and they may or may not lose consciousness. Infantile spasms, also called infantile myoclonus, massive spasms. They can also have hips arrhythmia, Salem episodes, or infantile myoclonic spasms. Most commonly, these occur during the first 6 to 8 months of life, twice as common in males as in females. The child may have numerous seizures during the day without post-ictal drowsiness or sleep. The outlook for normal intelligence is poor. Signs and symptoms. Here they have a possible series of sudden brief symmetric muscular contractions, the head flexed, the arms extend, and the legs draw up. The eyes may roll upward or inward. It may be preceded or followed by a cry or giggling. They may or may not be a loss of consciousness. Sometimes there's flushing, pallor, or cyanosis. Children who are able to sit but not stand may experience a sudden dropping forward of the head and neck with the trunk flexed forward and the knees will draw up. This is called a Salem or jackknife seizure. So diagnosis, here, history and physical, we want to question any witnesses to the seizure. Was there an aura, a scream, loss of consciousness, length of time? We want to check a CBC, a metabolic panel, CT, MRI. If they are on anti-seizure medications, we want to check their levels, do a lumbar puncture, and then they will do an EEG, which is the most helpful in diagnosing where the seizure originated. An EEG can be done while the child is asleep, awake, sleep deprived, with flashing lights, noise, and hyperventilation. A video EEG can be done while they're in all of these same situations, and the only difference is here they're actually videotaping the child while the EEG is taking place. It's important for the nurse to remember not to get in between the camera and the patient, because we don't want to block the camera from videotaping the child's EEG, especially if they start to have a seizure. Assessment questions. Did the child complain of not feeling well or feeling funny just before the seizure? Did the child complain of a headache, nausea, muscle pain, or vomiting? Did they suffer any kind of trauma? Did they get into any medications or poisons? Did the child's movements involve just one side of the body or one arm or leg? Did they injure themselves? Did they become pale, or did you see color changes? Did they lose consciousness? Were they sick or feverish? Were the movements tonic-clonic? Did the child's vision, was the child's vision normal? Are the pupils dilated, or did the eyes deviate to one side? Were they incontinent? How long did it last? When did the child begin to wake up? Afterwards, was the child lethargic, weak, with uncoordinated movements upon arousal? Treatment. If it is a febrile seizure, then they would give anti-seizure medications until the fever is gone. Otherwise, they will use anticonvulsant medications. Typically, we try to keep it to 1 or 2 medications to make it so that it's easier for the parents to manage. If that's not successful, then they start adding addition treatment modalities. Things like a ketogenic diet, which is high in fat, low in carb, and adequate protein. A vagal nerve stimulator for people 12 and over as an adjunctive treatment. Or surgery may even be necessary to remove a lesion or a part of the brain where seizures originate. Know that that's really a last resort. Medications commonly used for partial and tonic-clonic seizures are things like Tegretol, Dilantin, which is phenytoin, Cerebex, which is fosphenytoin, valproic acid. The drug of choice for absent seizures is Zerontin and valproic acid. Children taking phenobarbital or phenytoin, Dilantin, should receive adequate amounts of vitamin D and folic acid. Dilantin should not be taken with milk. It can be given through an IV only mixed with normal saline up to 50 milligrams per minute. Fosphenytoin, which is your Cerebex, can be given 3 times faster than IV phenytoin, and it may be mixed in normal saline or dextrose to solution. Also, please note, you do need to use a filter when you are giving phenytoin. Nursing. Definitely, we want to have a patent airway, right? It's always ABC, LOC. Don't put anything in the child's mouth. Give them oxygen if the oxygen is low, less than 95%, and then check the vital signs. Make sure as soon as they start having that seizure, put the child on their side. Safety. If they are people that have frequent seizures, they may need to wear a helmet. Definitely plat the side rails. We don't want to restrict movement. You want to protect the head from injury. They should be wearing a medic alert bracelet. That way people will know that the person does have a history of having a seizure disorder. You want to lay them on their side and then place an incontinent pad on the bed routinely, just in case they do have a seizure. You don't have to change the whole bed. You want to give medications per the doctor's order and monitor levels for the medications that require levels to be done. Dose may need to be adjusted as the child grows. Emotional support is very important because seizures can be scary for a parent and a child. You want to encourage both to verbalize their fears and anxieties. Reinforce the medication regime and side effects. Determine if the school nurse needs to give medications. Labs and follow-up appointments. Dental visits are very important due to phenytoin or dilantin can cause gingival hyperplasia. Therefore, it's really important for them to brush after every meal and make sure that they floss their teeth as well. You also want to use a soft toothbrush so you don't damage the sensitive gum tissue. Anti-epileptic medications can be stopped when a child has been seizure-free for at least 2 years and they have a normal EEG. The medications are gradually reduced using a stepwise approach over a couple of weeks. Repeat EEGs are obtained every 6 months to 2 years. In general, you can drive depending on your state law. Different states require different amounts of time that you need to be seizure-free. Some states it's 2 years. I've seen some states that it's just multiple months. So just double check with the state that you live in. They should avoid contact sports. They should swim with a companion and have supervision when using dangerous machinery. Family members should know CPR. They need to know how to use the vagal nerve stimulator if applicable. They also need to know how to administer diastat rectally. Teachers and caregivers should be aware of the disorder, and the helmet use may be required for safety. Information and nursing. During the seizure, you gotta time the seizure episode. Be calm. If the child is standing or seated, ease the child down on their side and place a pillow, a folded blanket, or something soft underneath their head. If nothing is available, just put your hands under the child's head. Don't restrain them, don't use force, don't stick anything in their mouth, don't give them anything to eat or drink. Loosen restrictive clothing, remove their eyeglasses if they have them on. You want to keep the area clear of any hazards or hard objects, and just allow the seizure to end without interference. If vomiting occurs, the child should already be turned on their side, but if they're not, please make sure you do so. After the seizure, you want to take a look at are they breathing? Again, ABC, check the position of the head and tongue, reposition if the head is hyperextended. If breathing is not present, definitely give rescue breathing and call emergency services. Also, check around the mouth for evidence of burns or suspicious substances that could indicate poisoning. Keep the child on their side. Remain with the child until full recovery. Do not give food or fluids until fully alert and swallowing reflex has returned. Call the EMS when necessary. Look for medical identification and determine what factors occurred before the onset of the seizure and that may have been triggering factors. Check the head and body for possible injuries and fractures. Check inside the mouth to see if the tongue or the lips have been bitten. Call EMS if the child stops breathing, there is evidence of injury, or the youngster is diabetic, pregnant, the seizure is lasting more than 5 minutes, unless the duration of the seizure is typically longer than 5 minutes by history. There are some people that have chronic seizure disorders that have seizures that are a bit longer than 5 minutes, but the parents know that this is the case, so they know when to bring the child into the hospital. They've been given the correct instructions. Status epilepticus occurs. Pupils are not equal in size after the seizure. The child vomits continuously 30 minutes after the seizure has ended. This can be a sign of an acute problem. The child cannot be awakened and is unresponsive to pain after the seizure has ended. The seizure occurs in water, so this is definitely a problem because they can go into shock and they may have aspirated. Also calling 911 if this is the child's first seizure. Status epilepticus, we already talked a little bit about this, but just as a recap, this is seizure or seizures lasting more than 30 minutes or a series of seizures in which the patient does not regain a premorbid level of consciousness. Therapeutic management, maintaining the airway and monitor for apnea, maintain the patient's safety, establish an IV, and then we need to give medications, IV diazepam or lorazepam. Those are your emergency medications. Typically, you will follow that with phosphonatoin, followed by phenobarbital, and definitely support the family because remember, this can be very scary. So IV lorazepam and diazepam are your first-line drugs. Lorazepam has a rapid onset, 2 to 5 minutes, and a pretty long half-life. So you want to monitor the vital signs and monitor for respiratory depression. When benzodiazepines are ineffective, phosphonatoin can be followed by phenobarbital. Here they also have a high risk for apnea and respiratory support. If they continue to have a seizure, then they may require generalized anesthesia and a continuous infusion of midazolam, propofol, or pentobarbital. In this case, they need to be intubated and they will be put on an EEG monitor. Nursing, again, it's ABCs, life support, monitor the blood pressure because hypertension can actually occur during the first 30 to 45 minutes and then it'll return to normal, but then it can actually drop due to the medications. Body temperature can actually be very elevated as a result of the increased motor activity. Febrile seizures. Here, after between 1 and 5 months of age, is typically when you'll see these occurring. It's more in boys than girls. They do have the generalized seizures, which are lasting less than 5 minutes typically, and it's usually with a fever over 101.8. The seizure typically occurs as the temperature is rising versus a prolonged elevation. They're usually benign. 95% never have epilepsy or neurological damage. And again, anti-seizure medications are given during an increased temperature, but not long-term. Again, if the seizure lasts longer than 5 minutes, take them to the emergency room. So an early sign of neurological dysfunction is decreasing level of consciousness. Using the AVPU method is an accurate method of assessment used in children. So what does the acronym mean? A stands for awake, V stands for verbal, P stands for painful, and U stands for unresponsive. So it means that they respond to you, they're awake, they only respond to verbal, they only respond to painful, or they are completely unresponsive. No, you gotta know a bit about Reye syndrome for your test, just a little FYI. Hydrocephalus. This is a disturbance in the balance of the cerebrospinal fluid, impaired absorption of the CSF within the subarachnoid space. The ventricles communicate, non-obstructive or communicating hydrocephalus. Or you can have an obstruction to the flow of cerebrospinal fluid within the ventricles. The ventricles do not communicate, so this is considered obstructive or non-communicating hydrocephalus. Signs and symptoms. Early infancy. Here you have abnormally rapid head growth, bulging fontanelles, especially the anterior, sometimes without head enlargement, tense, non-pulsatile, dilated scalp veins, separated sutures, Macewen sign, which is a cracked pot sound on percussion, and thinning of the skull bones. Later infancy, you can have frontal enlargement or bossing, depressed eyes, setting sun sign, and this is where the sclera is visible above the iris. Pupils are sluggish with unequal response to light. Infancy, general, here you could see irritability, lethargy. The infant cries when they're being picked up or walked, and they quiet when they're allowed to lie still. Early infantile reflexes, they may persist. Normally we expect responses to fail, and anyway, they may disappear. They have changes in their level of consciousness. Again, they can have that opisthoughtness, and it can be very severe. They can have a lower extremity spasticity, vomiting. In advanced cases, they can have difficulty in sucking and feeding. They can have a shrill, brief, high-pitched cry, and then cardiopulmonary issues. Childhood. headache on awakening, improvement after emesis or sitting or standing upright, papilledema, strabismus, extrapyramidal tract signs like ataxia, irritability, lethargy, apathy, confusion, incoherence, and vomiting. Diagnosis. This is based on the history and physical, daily head circumference measurements, head circumference that cross one or more percentile lines within 2 to 4 weeks, and they have neurological signs that are progressive, are indicative of this. CT scans that show dilated ventricles. Also with a dye injection, the cerebrospinal fluid flow can actually be monitored. And also they may do an MRI. Treatment. Here, if it's possible to remove a blockage, they will do so. If not, then they will divert the excess cerebrospinal fluid with a shunt. Ventriculoperitoneal shunts are most common. VP shunts are usually replaced 2 to 4 times as the child grows. Common shunt problems include infection or malfunction like blockage, kinking, or valve breakdown. Here you could see if there's an issue with blockage, kinking, or valve breakdown, increased signs and symptoms of ICP, signs and symptoms of hydrocephalus. Early signs of shunt failure are headache and decreased appetite. The most serious problem is shunt infection. It is most common in the first 6 months of placement. Signs and symptoms include ventriculitis, meningitis, low-grade fever, malaise, headache, nausea, and vomiting. Treatment. IV antibiotics for 7 to 10 days. They may need to remove the shunt and use an external drainage device until the infection is gone. Then a new shunt will be placed. Nursing, you want to check the head circumference every day or maybe once a shift. Check for signs and symptoms of VP shunt malfunction, signs and symptoms of infection. Keep the child flat after a VP shunt has been placed. We don't want to drain the cerebrospinal fluid too rapidly. This actually helps to prevent the development of a subdural hematoma. You want to gradually elevate the head of the bed per the doctor's order. Check the vital signs every 2 to 4 hours. Don't position the head on the shunt. Arbitrary pumping of the shunt may cause obstruction and other problems and should only be done under the direction of the neurosurgeon. They may be NPO for 1 to 2 days. Once their bowel sounds are present, they may feed small frequent meals because they are a little bit more prone to vomiting. Observe for abdominal distension because the cerebrospinal fluid can actually cause a peritonitis or post-operative ileus, so we do need to monitor for those signs and symptoms as well. Family support. Recognize signs and symptoms of shunt malfunction, know that contact sports should be avoided, and refer to any kind of community services. There is a National Hydrocephalus Foundation and Hydrocephalus Association. Again, we're going to change topics. Now we're going to talk a little bit about endocrine. Here, diabetes mellitus is characterized by a total or partial deficiency of the hormone insulin, the most common endocrine disorder of childhood. Peak incidence is in the early adolescence, around ages 10 to 15 years of age. There are 2 major groups, type 1, which is characterized by destruction of the beta cells, usually leading to an absolute insulin deficiency. Most cases of diabetes mellitus of childhood are type 1. This was previously called juvenile diabetes. Know that this is more typically diagnosed between 10 to 14-ish, but it can occur at any age from infancy to age 30. Type 1 is believed to be an autoimmune disease arising when a person with a genetic predisposition is exposed to a precipitating event such as a viral infection. So hereditary is a predominant factor in the etiology. Signs and symptoms, the 3 Ps, polyuria, polydipsia, and polyphagia. Weakness, fatigue, headache, nausea, vomiting, and abdominal cramps. So typically you'll see a blood sugar of greater than 130 before eating and greater than 180 2 hours after eating. That is considered hyperglycemia. They can also have glycosuria, ketonuria, and dry, flushed skin. Type 2 arises because of insulin resistance. This one's typically develops after age 45, and we see an increased incidence in Native American, Hispanic, and African American children. They are at an increased risk of type 2 diabetes. They may or may not require insulin injections, and typically this is seen in obese or overweight children who are physically inactive. In general, this occurs as a result of insulin resistance plus some insulin deficiency. Insulin resistance results in diminished liver, muscle, and adipose tissue sensitivity to insulin. Signs and symptoms: acanthosis nigricans, which is a thickening, hyperpigmentation of the skin at the neck and flexural areas. Hypertension, hyperlipidemia, and sleep apnea can also develop. Blood glucose levels at or above 200 milligrams per deciliter without fasting is diagnostic of type 2 diabetes. So, type 1, no insulin is produced and cells cannot use the glucose. Excess glucose in the blood spills into the urine. An increase in blood glucose can act as an osmotic diuretic, resulting in dehydration. So this is where you have your polyuria. You also have the polydipsia, because when you have dehydration, you get thirsty. They can develop hypotension, renal shutdown. Without glucose, the cells are starving, resulting in signals of hunger and increased food intake. This is where the polyphagia comes in. The body attempts to compensate for loss of energy by converting triglycerides to fatty acids, which then form ketones, resulting in metabolic acidosis. So ketoacidosis is when glucose is unavailable for cellular metabolism and the body is breaking down alternative sources of energy. Ketones are released and excess ketones are eliminated in the urine. So here we've got that ketonuria, or by the lungs, and here this is where you can smell that acetone breath or that fruity breath. Ketones in the blood are strong acids that lower serum pH and produce ketoacidosis. Kussmaul's respirations, this is that hyperventilation characteristic of metabolic acidosis resulting from the respiratory system's attempt to eliminate excess CO2 by having an increased depth and rate. DKA, this is a pediatric emergency. This results from progressive deterioration with dehydration, electrolyte imbalance, acidosis, and coma, and they can even die. Long-term complications of diabetes include microvascular complications like neuropathy, nephropathy, and retinopathy. Macrovascular disease includes cardiovascular disease, stroke, and peripheral artery disease. Typically, these develop after 25 years of diabetes. Predominant problems occur in patients with type 2 diabetes. Diabetic treatment includes insulin therapy, glucose monitoring, and we want to have a goal range of less than 126 milligrams per deciliter, laboratory measurements of hemoglobin A1C, urine testing for ketones. Generally, this is not typically used, except testing is helpful when it's done every 3 hours during an illness. So that's normally when you'll see it done, just when there's an illness, or if the glucose level is 240 or higher when illness is not present. Nutrition, exercise, and insulin management all go together. They all balance each other out. You want to teach the patient and the family how to manage hypoglycemic episodes, illness management as well, and then management of diabetic ketoacidosis. Meal planning is critical. You need to know how much the child should be getting. Are they on a continuous, consistent carbohydrate diet? And how many carbohydrates are they supposed to get? And based on the number of carbohydrates that they eat, that often determines the amount of insulin lispro they would be getting. So all of that needs to be balanced. It is important to know the different types of insulin, the duration, onset, and peak actions of the various types, and what medications can actually be mixed together. Remember, you don't mix any insulin with Lantus. Lantus is your long-acting insulin, and that needs to be given by itself. You can mix your Humalog with NPH or your regular insulin with NPH, but you cannot mix anything with Lantus, so that's very important to know. It's also important for them to know about glucose monitoring and keep good records of it, recognize signs and symptoms of hyper and hypoglycemia and know how to treat it. Also how to treat themselves when they get ill, because it's not uncommon when they become ill that they may have a higher blood sugar. So even if they're vomiting, as long as they're able to intake some fluids, they may need to be getting their insulin because their blood sugar could actually be very, very high. You want good record keeping. That way, when they go to the doctors, they can actually let them see what their progress is. Good hygiene is always important, and you need to have family support. Please make sure that you do know the different kinds of insulins. A little bit about age-specific care. There are many support programs and summer camps that can be helpful for children with diabetes mellitus. Delegation of diabetic activities based on growth and development. So guess what? The kids can help out with their care, and we want them to help out with their care because self-blood glucose monitoring is going to be very, very important for that middle school age child, because ultimately they're going to be taking care of themselves. So we want to get them started early, and they are actually developmentally ready to do so. But let's start with the preschooler. How can the preschooler help? Let them help with care by gathering the necessary supplies. Allow them to choose which finger or the location or the area to be poked. Allow them to choose foods that they can eat that are appropriate. So you're going to be giving them some choices. Identify a word that describes how they are feeling when they are feeling hypoglycemic. So that's very necessary. That's a safety issue. And then you want them to help hold still when you're doing the finger stick or when they're doing their insulin injection. School-age children, here they can check their own blood sugar and check their urine for sugar and acetone. That's definitely something that they can be taught. They can choose their injection site according to the rotation schedule. They know the signs and symptoms of hyper and hypoglycemia. You want to remind them and make sure that they are very aware of them. You want to make sure that they are carrying around hard candy or some type of simple sugar in case they do develop hypoglycemia. They should be taught their dietary needs, and then later school age, they actually can prepare and administer their own insulin. Adolescents should be able to fully manage their disease, plan meals and snacks, and we do want them to avoid risk-taking behaviors. Note that it's not uncommon for adolescents to come into the emergency room in DKA because they don't want to be different. So they might not be following their diet or not taking their insulin as ordered. Insulin, diet, and exercise must be balanced. If an increase in activity is not planned for, give them a snack, a 15 to 30 gram carbohydrate snack for 45 to 60 minutes of activity. If they're going to participate in a long sport practice, then they should take less insulin. You want them to wear a medic alert bracelet at all times. Glucagon may be given subcutaneously for severe hypoglycemia. Note that the glucagon only is going to last about 20 minutes, so it's necessary for the child to be fed afterwards. Place the child on their side as vomiting may occur. Signs and symptoms of hypoglycemia are things like behavioral changes, confusion, slurred speech, belligerence, diaphoresis, tremors, palpitations, and tachycardia. Lastly, we're going to talk about precocious puberty. This is defined as sexual development before age 9 years in boys and before age 7 in Caucasian girls, or before age 6 in African American girls. May be due to a dysfunction of the hypothalamus, the AP or adrenal glands. Earliest signs in girls are breast development and pubic hair. Earliest signs in males is scrotal development. This does occur a little bit more frequently in girls. There are 3 types. The first one is central precocious puberty. This accounts for 80% of the cases. Peripheral precocious puberty and incomplete precocious puberty are the other 2. Treat the child according to their chronological age in a developmentally appropriate way. While the child might become fertile, they usually do not display sexual interest, but interventions are needed if they do start to have those kinds of behaviors. In 50% of cases, symptoms regress or stop advancing and no treatment is necessary. Other options include monthly IM injections of luteinizing hormone, releasing hormone to regulate the pituitary secretion, or subdermal implants of gonadotropin releasing hormone. Treatment of the specific cause, if known, is great. For the central variety, often this is treated with leuprolide acetate, which is Lupron or Depote, and typically this is an IM injection. This slows to prepubertal growth to normal rates. The treatment is discontinued at the age at which normal pubertal changes would resume, and then psychological support for the child and family are necessary. This concludes the lecture addressing the behavioral objectives for week 6. Please be sure to read your textbook and complete the assignments for this week to facilitate the utilization of this content and apply it to nursing practice. Thank you and have a good day.